Okay, so for whatever reason, I did not get the last bit of chapter 16, postpartum teaching. That was like the third out of all the four. Anyway, let's go through it. We're studying for exam 2, and I really like her videos. Okay.
All right, let's talk about teaching topics for the postpartum period. If you like teaching, I'm doing patient education, then postpartum is the place for you. There's tons of teaching that happens here, and it's really fun. It's really rewarding. A lot of people really like it. So we're going to teach about pain management and discomfort. So this is pain management. So we teach them how to manage pain. It's not pain, take it away. So we have to just kind of go through, make sure that their pain's getting managed. Again, our goal would be that they're ambulating, that they're able to take care of their baby, right? They can still have pain. Some girls will deliver and have no pain at all and feel great, and others will have a lot of pain. Even in C-sections, they'll have no pain, and others can't even get up out of the bed or walk, right? It varies so much. So you just want to kind of take it on a case-by-case basis, help them manage their pain, provide pain medication as needed. Even just Motrins, Tylenols are usually effective for pain management. With narcotics, those are very appropriate, especially after a C-section, very appropriate, but it also makes you more sleepy. And when you're sleepy already and you have to get up in the middle of the night to feed your baby, and you're on narcotic and you're already exhausted, it's hard. So you try to avoid narcotics if possible. But again, narcotics after a C-section, very appropriate for that first week after the C-section. Immunizations, this is a hot topic. Everyone has different beliefs on it. The baby will get their first immunization in the hospital unless it's refused by the family. But hepatitis B is the first vaccine that's given in the hospital. It's typically given within the first 24 hours. And then they don't really get their next immunizations, the babies, until they're 2 months. So some parents will refuse the vaccines. If this happens, I'll always do education on the importance of them, but ultimately I respect them. I can totally get why you wouldn't want your 24-hour baby to have a vaccine, especially if your risk for hepatitis B is 0 to slim for future deliveries. Now, the baby's blood and mom's blood hardly ever will mix. But if there is trauma or anything like that, they can mix. And then sometimes after deliveries, they can. So we give this more to prevent future deaths or future pregnancies that are Rh positive. But if baby's Rh positive, then we're going to give Rogam in the first 72 hours after delivery. And this will help all right, let's our future.
I'm so good at this.
When you're sleepy already and you have to get up in the middle of the night to feed your baby.
I'm not
do education on the importance of them, but ultimately I respect them. I can totally get why you wouldn't want your 24-hour baby to have a vaccine, especially if your risk for hepatitis B is 0 to slim, right? So I get it. I don't usually argue too much about them. Some patients will refuse vitamin K and think that it's a vaccine. If that just helps with their blood clotting because they don't have those natural capacity when they're babies. So I'll encourage vitamin K a little bit stronger and a little bit harder. Just say it's a vitamin, it's a natural clotting factor, our bodies produce it, but the babies don't. But if they don't want it, then I'm gonna respect them and go on. My job is to make sure that they're educated and have correct information, and then they can refuse if they want. For adult vaccines, it's common that we will give the Tdap because the babies can't get Tdap for the first 2 months, and whooping cough is fatal to babies. So typically we'll give a Tdap to mom if she needs it. And then also to one other person, right, to family members. I think hospitals will do like to whoever's in the house. So they'll give a free Tdap vaccine to them. We also do flu vaccines, and then we give rubella, it's the MMR. So if their labs came back borderline or negative or non-immune, we'll give the rubella vaccine. The thing with rubella is it is a live vaccine. So if mom's planning on getting pregnant in the next 3 months, then we won't give it. Most moms, when you ask them that, will look at you like you're crazy. But I have had a few that have said, no, I do. I want to get pregnant right away. And so then we don't give them the rubella vaccine. Nutrition is a big thing. We really want to make sure moms are not in diet mentality. At this point, we want them to have a good diet full of nutrients, lots of protein, lots of iron because of their blood loss. This will help with their energy level also. They should be staying on their prenatal vitamins if they're breastfeeding. Their calorie intake should increase by 500 calories a day. And because nutrition is going to affect their milk supply greatly. So as soon as moms start cutting out calories, the milk supply will decrease.
Oh, yeah.
If your mom's not breastfeeding, then we'll just talk about a regular healthy diet, 18 to 2,200 calories a day. Activity and exercise, there aren't a whole lot of restrictions initially. They can continue their pregnant exercise level. If they're going to start something new or go into more rigorous exercises, they should slowly progress into that, especially because those ligaments are still soft that first month or so after delivery. So most women, it's just their routine has been broken up. They don't have the energy, they don't have the routine that they kind of need for a structured exercise routine, and this can be hard for a lot of people. So we encourage them to give themselves some grace and some patience and to kind of fit in their workouts when they can, and just to try to navigate this new world and what this looks like, and that it's just a phase. Like, it will go away and they'll be able to get their routines back eventually. So we try to help them focus on the good and focus on the baby and not so much on their routines and getting back to normal. Clients who've had a C-section will be advised to wait 4 to 6 weeks before they do any kind of heavy lifting. Walking is always encouraged as it promotes healing and has great psychological effects. Lactation, again, diet and water intake. These are the things that we'll be talking about. The baby should be eating every 2 to 3 hours around the clock for the first couple weeks. So we want to get that baby back to birth weight. We expect the baby will lose a little bit after delivery. And so we need to make sure that baby is feeding and getting nourished. So every 2 to 3 hours around the clock, their stomach is the size of a walnut initially, and then it will grow in capacity. So they don't need to eat a ton, but they need to be eating both breasts with each feeding. A lactation consultant should come and talk with them. We do encourage mom to wash her hands before she feeds to prevent infection, to wear a well-fitting bra, and to there's lotions or creams that they can put on their nipples to prevent cracking. Discharge, we just want to make sure that the baby's going home to a safe place and that mom has the support that she needs. So I usually ask, do you have everything that you need to take care of a baby? A car seat, a crib, air conditioning. Just want to make sure the baby's going home to a safe place. This is a great time to answer any questions, to ask for return demonstration on newborn tasks like feeding, diaper changing, and swaddling. We're kind of watching and keeping an eye on them the whole time they're in the hospital to make sure that they know what they're doing and that they don't need any help and support. Sexuality. So it seems like it's kind of a standard to say no sexual intercourse for 6 weeks. It's actually safe to resume sex within 2 to 4 weeks, just whenever the bleeding has stopped and the perineum has healed. So you can see this is going to be different for every delivery. So sometimes they just say 6 weeks just because it's easier. But some patients will need to wait longer if they've had a traumatic delivery. Typically, most physicians will recommend no intercourse until the follow-up appointment in the office so they can make sure that the perineum is healing appropriately and everything's intact. The client should also know that it's common to need lubricants until your menstruation starts again. And it could take a few months before the physiological reactions to sex will come back. So they just need to kind of have patience and know that it will come back again. Contraception should definitely be talked about in the hospital. It's happened many times that the patient doesn't think they can get pregnant, or they've been told to wait for 6 weeks and they don't wait, and then they come back for their follow-up appointment and they're pregnant again. So that comes with a lot more risk that way. So we try to avoid those back-to-back pregnancies that quick. But we just want to make sure that they do have a contraceptive plan and that they're thinking about that. And then we tell them about follow-up. So usually it's 4 to 6 weeks after a vag delivery. And if it's a C-section, they usually see in the office about 2 weeks to make sure that your wound is healing, and then they'll see you again in 6 weeks to make sure that uterus and everything is going okay. Prior to discharge, we're going to make sure, we should already know this, but the blood type and the baby's blood type, and if RhoGAM is needed, we give that within the first 72 hours. If mom is Rh negative and the baby is Rh positive, so if mom has a partner that's Rh positive, the father of the baby, then that's at risk for cross-contamination for future deliveries. Now, the baby's blood and mom's blood hardly ever will mix, but if there is trauma or anything like that, they can mix, and then sometimes after deliveries they can. So we give this more to prevent future deaths or future pregnancies that are Rh positive. But if baby is Rh positive, then we're going to give RhoGAM in the first 72 hours after delivery, and this will help protect the future babies. It's an IM injection.
Okay, so the question is, during pregnancy, what is Rh compatibility? During pregnancy, a small amount of baby's blood can mix with the mother's blood. If the mother is Rh negative and the baby is Rh positive, inherited from the father, the mother's body can recognize the Rh protein as foreign and produce antibodies against it. These antibodies can attack the baby's red blood cells, potentially leading to anemia, jaundice, yellowing of the skin, or other complications in the baby.
Injection.
How does RhoGAM work? So RhoGAM is an injection containing Rh antibodies. It is typically given to Rh negative mothers at specific points during pregnancy, between like 26 to 28 weeks gestation and after delivery, so within 72 hours after delivery. The RhoGAM antibodies act like decoys. They bind to any Rh positive fetal red blood cell that enter the mother's bloodstream, preventing the mother's immune system from creating its own antibodies against the baby's blood. Benefits of RhoGAM. So RhoGAM is significantly reduces the risk of Rh incompatibility and its complications for the baby. It helps ensure a healthy pregnancy and protects the health of future Rh positive babies and the mother may have. And that's it for the chapter 16 postpartum teaching topics.